Welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member of the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. And I'm a family physician at the Gateway Family Health Clinic in Moose Lake, Minnesota. I am your host for our program tonight on diabetes. Remember, the success of this program is dependent on you, the viewer. So please call in your questions tonight or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening are Dr. Addie Vittorio, I'll get it right yet, the family medicine physician at St. Luke's Mount Royal and Leicester River Medical Clinics, and Dr. Umar Siddiqui, a internal medicine specialist with St. Luke's Internal Medicine Associates. Our medical students answering the phones tonight are Riley Berg from Bemidji, Minnesota, Sabdi Bravo of Lismore, Minnesota, and Tommy Gentle from Baudette, Minnesota. And now, on to tonight's program on diabetes. Welcome.
Hi.
Thank you.
How's it going?
It's good to have you here tonight. Omar, you're new to the area. Welcome to Duluth.
Thank you.
You want to tell us a little about yourself?
I'm from New York. I moved here about 14 months ago. I'm board certified in internal medicine and addiction medicine, and I love it here so far.
And you practice where?
At St. Luke's Hospital.
Very good. Addie, we've done this before, but tell me again.
So I am a native Duluthian. I grew up here. I was in the cities for a while and came back, and I practiced at 2 different clinics, 2 days a week at each for St. Luke's.
Well, welcome back.
Yeah.
Addie, let's start tonight with just start out describing what diabetes is and start us down the road, and we can branch as we need to.
Yeah, and diabetes is a very broad topic, so I would imagine we're going to be addressing a lot of things with this. But diabetes essentially is a disorder of what we call glucose homeostasis. So there's a certain amount of glucose that you should have circulating in your blood at all times for management of our processes of our body, but also to maintain sort of safe levels in the blood so we're not getting damage from those blood sugar levels. And so diabetes is a disruption of that in some way, and there are actually a couple different classes of diabetes, and they're caused by very different things. We know that type 2 diabetes is typically what we would call starting with insulin resistance, or the body doesn't really know how to use blood sugar properly because of obesity or other things going on in the body. And diabetes type 1 is typically a disorder of the pancreas wherein autoimmune processes destroy our insulin producing cells, and we are no longer able to manage glucose in that manner.
So in type 1, you really need insulin.
Yes. That is the requirement.
So Omar, on type 2, what are some of the things that make type 2 diabetes happen? What are genetic or other things?
Some are genetics. A lot of it can be hormonal changes leading to insulin resistance. So that's why some of the medications that we use help kind of sensitize the cells to insulin, like metformin. But eventually, some patients will end up with type 2 diabetes on insulin as well.
And so there's a genetic component. Weight's a factor too.
Yes.
I guess that's one thing we have to remember also. So lifestyle.
Yes.
And as I look back and watch and remember back to the 60s, I'm old, we were a lot thinner in those days. What's happening with diabetes? Are we seeing more and more of it?
I think we're seeing more and more of it, but also screening more and more for it. So I think we're trying to catch it earlier before it becomes something more out of control, before it leads to some of the like heart disease and other things that can arise from it, strokes, heart attacks. So I think catching it earlier, managing it earlier leads to the prevention of other diseases that can arise from it.
Yeah, and we are seeing it earlier as well, more so in younger populations. So we're screening and seeing diabetes in younger adolescent populations that are obese. We're screening pregnant women more often, and we're finding that women who have either genetic factors or obesity throughout their pregnancy are at high risk of developing not only diabetes later on, but also throughout the pregnancy. And the diabetes caused by pregnancy is called gestational diabetes. That's caused by a totally different entity, but it does still place people at risk for diabetes later on in life.
How do you diagnose diabetes? I'm looking at you.
Okay.
I'll let you
we
start with the
diagnose
family doc.
diabetes in a variety of different ways. So you can essentially diagnose diabetes by a random blood sugar that is very high. You can diagnose diabetes by a fasting blood sugar that is elevated, but we always confirm that with what's called a hemoglobin A1C. And a hemoglobin A1C is a lab test that's dependent, it's a molecule on our hemoglobin or our red blood cells. And it's circulating in the body at all times. And if you have higher blood sugars, your actual hemoglobin molecule, part of it, becomes glycosylated, or it has more blood sugar byproducts attached to it. And so a hemoglobin A1C of greater than 6.5 is diagnostic of diabetes.
Umar, where do you try to keep your diabetics? At what level on A1C?
Ideally below 7, if we can.
Below 7?
If we can, but I like to see any kind of improvement in my patients, because then kind of, and working from there. It's hard to make each patient kind of individualized treatment. It's hard to create a standard for everybody.
I want to take and step aside for a moment and welcome Ken Ripp.
Bad day. Bad day in the office.
Welcome. Nice to have you here. Ken is with CMH, or Community Memorial Hospital, Rader Clinic.
Yep.
You want to tell us a little bit about your practice, Ken?
A standard full practice family medicine, and been doing it, and been down in Cloquet for coming up on 30 years. So.
Well, welcome.
Thanks.
The question discussion is getting back to type 1 and type 2. We kind of covered the differences. Is there an increased risk of type 2 diabetes if I have a family history of type 1 diabetes? Ken, I'll just put you on the spot right away.
Type 1 and type 2 are very different disease states. So your family history of type 1 does not raise your risk of type 2. Now, if you have type 1 or type 2 in your family, you're more risk for that type. But mostly it's type 2 that is more genetically linked in family. We see it cohorted in a family.
When you diagnose diabetes now, and someone new, what's your first treatment? Omar, I'll look at you on this one.
Depending on the A1C, usually lifestyle modifications, exercising more, diet alterations, something that's more manageable. And we can repeat the A1C every 3 months, so you can kind of come back in 3 months and see where they're at and how much improvements that they've made with lifestyle modifications alone. If they hasn't made much of a difference, then we would start them on some kind of medication.
What's your first thoughts on diabetes treatment then?
Yeah, well, that's changed. Probably even in the past 2 to 3 years, our mindset has changed, and guidelines have changed as well. So it used to be since the 90s when metformin came out that we would start metformin on every patient, and that is still, for a lot of patients, the way to go for medication. That medication improves insulin sensitivity, so it allows our cells to use blood sugar more effectively and sort of fixes the initial problem found. There are people who either don't tolerate metformin due to some of the side effects, like gastrointestinal side effects, or who might be a better candidate for some of our newer medicines. And people are very familiar with the names Ozempic or Mounjaro, and those are names of a class of medications that do a lot of good things for blood sugar, but also have a significant amount of weight loss associated with use. And inherently in type 2 diabetes, if weight is one of the issues, that additionally helps.
Omar, your thoughts on how you handle it? Pretty similar?
It's pretty similar. I do agree metformin is still used pretty commonly because a lot of it's because of cost, because Mounjaro and Ozempic are still fairly expensive if your insurance doesn't cover it, so it kind of depends on what we can do for the patient.
What are your thoughts on exercise? Ken, you're the exercise guru here.
So when someone is diagnosed with type 2 diabetes in my practice for the first time, I tell them this is your chance to embrace this diagnosis, or you can reject it. If you embrace it, that means you embrace the lifestyle changes that it takes to get improvement. And I have had patients who've had, seen their A1Cs go from well above 10 down to 7 with radical lifestyle changes. Movement really helps unlock the key to type 2 diabetes, which is getting the insulin that is in the bloodstream to work to get the blood sugars into the cell. The more you move, the better that system works. The less you move, then the system breaks down. So if people embrace exercise and they can really see it make a change, The continuous glucose monitors are really helpful for patients because they can see the impact exercise has on their blood sugar. So some people wear them all the time. Some people use them for a few weeks when they work with a diabetic educator, which is very helpful, and they can see the impact of exercise on their blood sugars. But it takes time for the body to fully, re-engage.
You brought continuous glucose monitors in. Either of you want to comment on those?
I mean, I think they're great. I think they, again, gives you glucose monitoring throughout the day, not just when you're poking your finger and checking it yourself, which I also feel becomes cumbersome, and nobody wants to poke themselves. This is something you kind of slap on, kind of forget essentially for 2 weeks, and you kind of check your triggers and get a better, more accurate reading throughout the day when the fluctuations are. So if you do need to make any adjustments, that gives you better insight.
The question here is, I've seen reports that metformin can cause dementia and possibly develop overextended use. What are your recommendations on the recommendations on the use of metformin? And I think we just kind of went through that. What kind of side effects are you seeing with metformin? I just open it to the panel. Mostly GI, isn't it?
Yeah, mostly it's nausea or diarrhea. There's always going to be an association with these metabolic conditions and the medications we use for these metabolic conditions, because what increases your risk of dementia? Well, having heart disease does. Having strokes increases your risk of dementia. Having diabetes can increase your risk of dementia. So it's really difficult to pick apart that a medicine causes this or it's being associated with this. We still use metformin. It's a great drug. We sometimes would see a depletion of some of the B vitamins, like B12, but that's treatable with supplementation.
Umar, type 1, the question is, what modern advances have we seen in fighting type 1? And we talked about the continuous glucose monitoring. Is there anything else on the horizon or thoughts? Or any of you, but I lean towards you a little bit on this one.
Trying to think.
I've seen a lot of patients use the continuous glucose monitor that interfaces with a pump now. And so that's probably the biggest change we've seen, is that the pump will automatically adjust your insulin level based on what your blood sugar is, based on an algorithm.
And just a reminder to the question, between type 1 and type 2, with type 1 you need insulin. With type 2, you usually do not use insulin. Is that correct?
Yes.
And do you see a lot of older people that convert or become type 1 with their diabetes? I think once in a while I've seen one or two maybe.
The question you're asking is, do type 2 diabetics, or do older
they,
persons
yeah,
get
do they
type
turn
1
to,
diabetes?
Can they go to type 1, or are there type 1s? Yes.
If their pancreas just gets so tired that they're no longer producing much or any insulin, they're not, if you measured the specific test, the C-terminal peptide, to see if they're making any, they're probably making some, but they're making so little that they're basically a type 1. And type 2, and type 1s can have an overlying type 2, meaning that if a type 1 gets obese and sedentary and they have a strong family of type 2, they can get resistant to their own insulin that they're injecting. So we see that once in a while, and sometimes we end up putting them on some medication to help try and change that dynamic.
The interesting thing about diabetes, at least type 2, is that if you're diagnosed after the age of 65, you're very unlikely to sort of progress as rapidly as those who are diagnosed in their 40s, 50s, and 60s.
Carb counting. Anyone want to take that on? The question is, can you clarify carb counting and insulin dosing?
I think that takes the scope of a diabetic educator and a dietitian to really measure what a carb is and how your own body responds to that, because carb counting and your insulin ratio depends on a variety of factors.
Agreed.
Good answer. I like that.
Okay. This person's been a diabetic for 24 years and has been having trouble with high blood glucoses in the morning. Why might that be?
I mean, it's hard to
And
This would be a great one for a continuous glucose monitor, because they could be just steadily rising overnight. Whatever medications they're taking during the day wears off at night, or they could be dipping at 4 in the morning, and then their liver is pushing out a whole bunch of sugar in the morning and giving them a high. So a continuous glucose monitor would be helpful there. Or if they're up at 4 in the morning for whatever reason, they can check and see where are they before sunrise.
Yeah, and there's a hormonal effect that sort of happens in that early morning hour where we do see people go low. We also encourage people not to snack before bed because that raises your morning and early morning blood sugars the most.
Along those same lines, this person's husband is an insulin-dependent diabetic. Whenever he is walking or exercising, his blood sugar goes between 250 and 300. Why is that? So this is with exercise as I read this question.
It's probably difficult to know, based on that one scenario, but any stress to the body can can cause an increase in blood sugar levels. The counteractive thing is that exercise should help lower his blood sugars. So it's hard to tell just from that one.
It depends on how long it lasts. If it theoretically should come down after the exercise is done as the body's kind of resetting itself.
Yep, I agree. So let's talk a little bit about the new medicines. Ozempic's on the all over everything. Who wants to take that one on? Ken, you're sitting there.
I'm in the hot seat, I guess.
Yeah, you're listening.
So Ozempic is an injection. It's once a week. The injection is not painful. You can get a little knot there. It does work on a system that plays with your satiety center. So people who are on it say, you know what? I just don't eat as much. I eat, half. I go out to eat and I can only eat a half or a third of the plate, and the rest I'm bringing home because I just can't eat it. And so it is a good, that is one mechanism on how it helps the body lose weight. It works on other systems as well. The nice thing is it does have cardiovascular benefits. So one of the things that we've tried to do with diabetes and all diseases is, okay, we can change a number, but do we affect outcomes? And Ozempic in that class is building data that, yes, you're going to have less heart attacks and less cardiovascular disease, which is a big deal to us because that's very expensive. So people who are on it, it's a very slow taper up, and you have to be patient. And people, for the most part, like it, but the problem is coverages and insurance. I've had many people who start it and are on it for a while and have to come off because of cost. They hit the donut hole, they can't afford it, or their insurance, their deductibles get just too high, and they can't afford it because it is very expensive.
And because it's used as a weight loss med, we're seeing lack of availability.
Yes.
And our pharmacies have really started gatekeeping that. I heard from a patient today that because she's not diabetic, but she is overweight, she can't get her medicines until all the diabetics have filled their medications, which is a good thing.
Yeah,
It's a good.
But it's hard to get. It's not a miracle. You still have to do the work with diet and exercise.
It is when I get requests for multiple times a day.
And there's also, I think, some black market availability, which is concerning too.
The concern would be, is that actually
Yeah.
FDA-regulated medicine?
You don't know what
versus-
you're getting.
Yeah, you
It's
don't
just,
know.
you
Would
have
not be
no
advised.
idea. We don't have a long, I don't know. Omar, have you read any of the studies on Ozempic? How long has they followed it out? I know that there are some side effects that come with it.
Some side effects if you have these contraindicated patients with pancreatic cancer and thyroid issues, but as far as long-term side effects, I'm not sure what the studies have shown. It's only
and
been
the
around
hard
for
thing
a
is
few years.
you don't want to be the first person to use a
Use.
medication, and you don't want to be the last
Last,
person to
right.
use it. But we don't know 10 years from now, what do we do when someone loses a great amount of weight and they're no longer diabetic, but they're on Ozempic? Do we cut back on it? What's our plan at that point? What do we see in 20 years on someone who's used Ozempic for a period of time?
So that brings up the question, can you cure diabetes? Let's say type 2.
My answer would be yes.
Theoretically, yes.
Yeah.
Theoretically, and weight loss is the,
That person will be forever metabolically changed, so they're always at risk. You don't go back to completely normal. And the other new classes of drugs that we've been talking about, the flozins, have been also game changers for us because once again, these drugs have cardiovascular and renal protection, which we were very surprised at. I don't know about when the drugs first came out, I'm like, this drug is not going to be good. And surprisingly, it's been very protective to the heart, lungs. You get weight loss, and it's a pill, which for some people is nice.
Yeah, and what we're talking about is a medicine that you take orally that increases the amount of blood sugar in your urine. So you're wasting calories, but you're also lowering blood sugar at that point.
Right. I thought it was going to gum up the kidneys and make your kidneys worse. And
so is there a brand name that you want to put on that? Because
There's
Jardiance,
three different.
Farxiga,
Farxiga,
and
yeah.
what's the other?
Invokana.
Invokana.
I've been on metformin for many years, is there anything I can do to get to the point where I no longer need to take the medication? And we've talked about that. It's with weight loss. We've talked about cures for diabetes. There really aren't. Is there a point where you get in trouble with metformin? That drug has been around for a long, long time, and as far as I know, is a very, very safe drug. And I just opened up to the panel. Any thoughts?
I mean, I've had patients who've been on it for decades without any kind of issue. I've had patients who were diabetics on metformin and kind of weaned themselves off of it, and I'm managing with diet and exercise, but I don't. It's hard to say. It's hard to make a blanket statement of coming off metformin. It'll have to be if the other changes are made with weight loss and exercise and A1C tracking.
And it was developed in the 1920s, and then insulin came about, and we sort of forgot about it. And we used another medicine instead of metformin that was very similar that had some side effects, like lactic acidosis is what we always talk about. So there's a theoretical risk of that, and that's where acid builds up in your system and you get some metabolic changes. But we haven't largely seen that.
Ken, you're the exerciser. I think everybody's an exerciser, but I know you are. Circulation, what can you do for poor circulation in the feet?
Well, there you already gave the answer. Movement helps. We know that patients who have, if there's actual poor circulation, meaning narrow blood vessels in your legs, if you exercise to the point of pain several times a day, your body will begin to create new paths around blockages. That is one thing. Now, you can also go, get some testing done, and maybe you do need a procedure to really open the vessel up. But short of that, those are the two majors. There are some medications that are a little bit helpful, but it's exercise regularly. And it's to the point of discomfort is what the literature was saying, is you got to work it until it hurts a little bit and then back off and then start again, sort of forcing your body to get better.
I've always said that angina in the calf is not dangerous.
Yeah.
So you just keep going.
Unless a toe falls off.
Yeah. What about heart disease? Either one of you want to step in on that?
I mean, again, I think exercising is a good way to help improve your cardiovascular health. I mean, obviously, you stop, you get chest pain, shortness of breath, but to exercise more, push yourself as much as you can to help improve those conditions.
We've kind of touched this before. What type of increase in diabetes prevalence have we seen in modern society?
I've seen a lot. I think a lot of it is due to the availability of ultra-processed foods and snacks, and it is ultimately cheaper than eating healthy. And it's easier to grab a bag of Cheetos than it is to grab a bag of carrots.
And lack of movement.
Yeah.
Smartphones.
Mm-hmm.
Inhaled steroids. What effect do they have on the A1C?
So they'll, in some people, increase that. There's a little systemic absorption of the inhaled steroids. If you're on high doses or you use, quite frequently, we would typically see the A1C go up really with systemic steroids or even articular steroids.
Joint injections?
Yeah, and we'll see that in patients who get a joint injection and their blood sugars are in the high 200s to 300s for a week or two after their injection.
Any other complications we should talk about? We've talked about vascular, infection. Mm-hmm. Infection's a real problem, I think, sometimes. So good diabetes control. Other thoughts on that?
Kidneys?
Eyes.
Oh, kidneys,
yeah.
Kidneys.
Important.
Eyes.
Nerves.
Important.
Diabetic neuropathy.
Yeah.
If you want to get, so
Tell me about that a
an
little bit.
unfortunate complication to people who've had diabetes, either poorly controlled over a long period of time, is that the nerves begin to break down a little bit, and you can get just very bad pain. And it's a difficult pain to treat. There are some medicines that are indicated for it that can be helpful, but it is a tough one, and you feel bad for your patients who have it because we can't easily fix that.
Diabetes affects the small blood vessels and the small nerves because things sort of get gummed up with sugar byproducts and other occlusive things.
So I'm a young person. What can I do to keep from getting diabetes?
Stay a healthy BMI.
Have a good balanced diet, exercise.
Yeah, that is the best.
Keep your stress level low. Sleep well.
How much exercise, Ken?
Don't drink your calories.
Yeah.
And
That's a really good point.
well, that's right.
Yes.
So it is. So, a shameless plug, my wife was a diabetic educator, and I sent her one of my gestational diabetics. And she tells me, oh, by the way, she's drinking a case of pop a day. And once we eliminated that, it went away. So, trying to move every day. And I tell people, make it fun, make it interesting, and just do a little bit more than you're doing now. And because I don't tell people, you don't need to run a marathon, but if you just increase a little bit, it does build on itself.
I want to thank our panelists. This has been a great discussion. Our panelists are Dr. Addie Vittorio, Dr. Umar Siddiqui, and Dr. Ken Ripp, and our medical student volunteers, Riley Berg, Sabdi Bravo, and Tommy Gento. Next week, join Mary Morehouse for a program on child and adolescent mental health. And thank you again for watching. Have a great night.